Ladies and gentlemen, shall we make a start? Normally, at something like this, somebody would thank you for coming. This isn't where I live. This is where you live. So thank you for coming all the same, particularly on a night, wishing my life away, an afternoon like this. I'm from Manchester, so these are drought conditions as far as I'm concerned. But I do appreciate you coming out. Presumably, we were expecting a few more, as you can see from the seats. Presume the weather has perhaps put a few people off. My name's Andy Mills. I'm an independent chair, which is a position that's offered by an organisation called the Consultation Institute, which is the organisation I work for. It's a body that helps NHS organisations, local authorities, utility companies, anybody that has a group of people who use their services and needs to speak to those customers or service users or patients on a regular basis to help them plan their services. And we advise organisations on how to do that in a fair and transparent way. Tiny bit more about me. I've been involved in public services, local authorities, voluntary sector, education for hundreds of years, as you can see how ancient I am. But I've also been a community activist, chairing my community association in my hometown. So I'm kind of aware of what communities want from public organisations when those public organisations are consulting, and what the rules are as far as the consulting bodies when they need to speak to their users and their residents, etc. So we're going to have a short presentation in a minute from my colleague on the left here, and they will introduce themselves in a moment. We'll then do some questions and answers with the audience. We'll have a microphone going round, and there's two reasons for that. One is to make sure everyone can be heard, although I think we're a fairly small but beautifully formed group this afternoon, but also so that we can record the proceedings. And that is so that we can post those recordings on to the website, and anybody who wasn't able to make it today can then catch up with the proceedings. We would like you, if possible, to introduce yourself when you want to ask a question, but if you don't want to say who you are or who you represent, that's entirely down to you, up to you. In terms of some very quick housekeeping, we're not expecting any fire alarms. Places like this, I'm sure we'll notice if the fire alarm goes off, and if you look around you, there are a number of fire exits. The loos are where we all came in. I think the gents' loo is a bit more of a find, but it's more towards the kind of front of the hotel. And if you have mobile phones and iPads and iPods and all that kind of stuff, if you could kind of silent them, that would be really helpful. So if I could ask the panel to start with just to say briefly who they are and what organisation they represent, would that be okay?
I'm Debbie Frick. I'm Director of Strategy at North Cumbria University Hospitals Trust. That's all right.
Good afternoon, everyone. My name is Peter Rooney. I'm the Chief Operating Officer for NHS Cumbria Clinical Commissioning Group.
Hi, good afternoon. My name's Andrew Brittlebank. I'm a clinician and I'm Medical Director of Cumbria Partnership Trust, which is the organisation that provides mental health and community care services to the county.
Hi, good afternoon. My name's Rick Shaw. I'm Service Development Manager for North West Ambulance Service.
Great. Was everybody picking everybody else up there? Could you all hear properly? No. Gentleman on the end there, if we could. I think we have kind of stuck you on the end there, Rick, if that's all right.
No, my apologies. It's Rick Shaw. I'm Service Development Manager for North West Ambulance Service.
Okay, just so we get an idea of who's in the room, is everybody here from the local kind of Carlisle area? Do you call yourself Carlonians or Carlites or? Carlisle, okay. Okay, thank you. Do we have NHS staff in the building? Great, nice to see you. I think there's only two types of people, aren't there? Kind of, you're either in the NHS or you're not. You're either in the local area or you're not. So thank you for kind of explaining who's in the building. Okay, good. Debbie, would you like to kick us off?
Indeed. It's nice to see people here from Dalston. That's my nearest village, and I'm looking forward to bonfire night. Okay. So just a little bit of background, first of all, about the consultation process itself. The Cumbria Clinical Commissioning Group has actually got the legal responsibility for leading the local consultation. Consultation's about dialogue, it's about influencing decisions and helping the CCG in their role as commissioners to secure the best possible services for the available funding. However, obviously the Clinical Commissioning Group, the CCG, doesn't do this by itself, so they've been working very hard with all of the other NHS organisations and the local authority and the success regime. You know, if I can just stop there on the success regime isn't a bunch of people parachuted into this part of the country. The success regime is all of us. It's all of the organisations, the local people, the communities, to make what we can with what we've got to the best possible effect, working closely between ourselves and with some help from the national experts. So the national experts are thought of as a success regime, but these aren't their proposals. These are our proposals as NHS organisations. Outcome of public consultation is obviously an important important factor in decision making, but there's lots of other considerations as well. So what's really important is that at this stage, no decisions have been made. Nothing's predetermined. We are here to listen to you. All of this builds on a year's worth of engagement and work with communities before then, but we need to improve in how we engage with local communities so that we're really building our services together. There will be independent analysis of every single response. It doesn't matter if people have filled out half the form or part of the form, sent in a letter. It'll all be analysed independently, and those results will be passed to the Clinical Commissioning Group, who will consider, in partnership with the other NHS and local authority partners, what that tells us. The Council, I think it's important to say, have already consulted on some of their commissioning priorities in social care. Won't be any decisions made until the spring of next year. Public consultation is not a vote on or a veto over any form of change. So really important to remember, nothing has yet been decided. We've got some really big challenges facing us. We're not unique. I'm sure that you've seen in the press nationally all of the challenges which face the NHS and all public sector areas. We are blessed by technologies and improving health, improving economics of the country, meaning that people now live much longer than they ever did, but that does put an increasing strain on our health services. And nationally, there are financial pressures, something like 30 billion pressures worth by the time we get to 2021. We have some particular challenges here, some of which are shared by the rest of the country and some of which are slightly more unique to ourselves, generally because they're more pronounced rather than them being wholly unique. So our overall population health is not good in some areas. It's excellent in some, but in others it's not so good. So everywhere we've got an increasing population in terms of age, but we are what has been called super aging, so that by 2020, perhaps a quarter of our residents in our communities will be over the age of 65. We've also got gaps between life expectancy in some areas, and in some areas that can be as much as a 20-year or almost a 20-year gap in life expectancy between the best and the worst areas. There's also pockets of significant child poverty, there's problems with childhood and adulthood obesity, alcohol, substance misuse, so there's a lot of health issues that face us in particular. Probably our biggest problem is our difficulty in attracting doctors and nurses and other health professionals, and that is something that goes right across all of the healthcare provision. It's not just about secondary care, it also is affecting primary care where we've got large numbers of vacancies. It's not also about just doctors, it's also about nurses. So both the Partnership Trust and the Acute Trust providing secondary care services have something in the order of 25% vacancies for their consultants. And we have to fill those by locums, interim doctors. And the impact of using interim doctors is twofold. One, financial. They're very, very costly. But two, is because they don't necessarily provide the sort of continuity which enables teams to have the right sort of leadership to improve services, make services more efficient, move with the times. So medical leadership is a particular issue. Lots of reasons for why we can't attract doctors. Many people would say, well, unfortunately, West, North and East Cumbria are somewhat at the end of the food chain when it comes to attracting doctors. So in other words, where there are national shortages of doctors, the northeastern Cumbria, which is the area we organise into, tends to come last. And then within the northeastern Cumbria, this part of Cumbria tends to come last as well. And it's for a variety of reasons, but it comes down to, in many instances, the size of our teams. We're delivering small teams, the desire of doctors to specialise more and more, and the difficulty within small teams of being able to specialise when you need to be a generalist to cover everything. What we have available in terms of the opportunity to move jobs without having to uproot your entire family, and other issues which relate to the local area, such as housing and schools, etc., which unfortunately make this part of the country less attractive to some of our medical colleagues. We also have proportionately more hospital admissions and longer stays than we would want to see. And when we've looked at this, undertaken work to look at each and every patient in a hospital, community hospitals included, at any point in time, we have recognised that many of our patients are not in the best place for them at that point in care. And I'm sure all of you have heard about blocking of beds and delayed discharges, and at any point in time we do have a number of patients who are officially recognised as patients whose care would be better managed in another setting. So we need to do something about bringing people unnecessarily into hospital, including community hospitals, and ensuring that they can be supported and helped to be able to get back home as quickly as possible and not come back into hospital again afterwards. NHS is significantly overspent. We'll come back to that later, but I think the important message in here is that, yes, we have an enormous financial challenge here, but the changes we're going to be talking about that have been outlined in the consultation do not make any significant contribution to that financial challenge. We will have to make incredible efficiencies and change our ways of working in order to meet that financial challenge. So the services that we're describing are about quality and safety. They are not about financial cuts. We know that the CQC has deemed some services inadequate. So CQC stands for the Care Quality Commission. They regulate us in terms of quality, and it is them who have said that some of our services are not meeting patients' needs in terms of the promptness of care that is available, for instance, and that there are some elements that need improvement. And medicine at West Cumberland Hospital was deemed inadequate by the Chief Inspector in terms of quality, and he also noted a number of other areas which were extremely fragile and which needed to be tackled. Certainly, not knowing where our services might go next isn't helpful for any of us. It's not helpful for you. It's not helpful in terms of recruiting doctors. It's not helpful for the staff who are living with the uncertainty. But I think what's really important is that it is imperative that we tackle these difficult issues, and we need the public's help in making the decisions to ensure that we secure the best possible health care for our residents. We must build on the previous work, but importantly, it's absolutely critical that we tackle some of these difficult issues that perhaps have not been tackled in the past. Most importantly, it's really fundamental that we modernise our services, we move with the times. Patients deserve the most modern services in order that we can deliver the best possible outcome. So we have a vision for healthcare in West, North and East Cumbria. We don't just want to be on the back foot at the end of the food chain. We want to be somewhere where people really want to come and work, where we have services that are designed across all partners and with communities, where we have a centre for learning, where we base what we do on teamwork and modern approaches, and where then we are recognised not as somewhere that's on the back foot, but as somewhere that is a real centre for excellence in terms of joined up health and social care provision for remote, rural and dispersed communities. We need to have some really exciting new ways of working in order to achieve that, new approaches to workforce, and we need to ensure that we partner with academic institutions such as the University of Central Lancashire to ensure that we can get some of that action research and show that what we can do in West, North and East Cumbria to become a remote and rural health provider is second to none. Our integrated care communities, these are the absolute foundation stone of what we're trying to do. 8 areas joining up care for communities of between 20,000 and 70,000 people, involving all of the partners in care, NHS, social care, voluntary sector, but also critically important, patients, their families, their carers, to make sure that we can deliver care that is really focused in around the patient as being at the heart of it. So we have a patient and their families and carers right at the centre, supported by their primary care teams that we know you value immensely, your GPs, your community nurses, and ensuring that they are able to coordinate your care, bringing in specialists when necessary in order to keep people at home or close to home wherever possible, remain independent for longer, not needing to go into residential or nursing care, not needing to attend or stay in hospital, and with much greater use of technology and home adaptations to help us, particularly important, of course, in a rural area. So we need to embed our vision for our integrated care communities and make lots of other changes in terms of efficiencies and quality improvements so that we can provide safer services that are of higher quality, that are clinically and financially sustainable. So the services that we are consulting on must be seen in that context of the integrated care communities. It's really, really important. This isn't just about changing one or two relatively small activity areas in hospitals or in community hospitals. This is about changing an entire way of working based around patients within their communities. Children's services. We've got inpatients and outpatients on both sites at the moment, and we have what's called short-stay paediatric assessment units in their infancy on both sites. We've got a lot of challenges, particularly around consultants and also some special care baby unit nursing, and that we are currently operating at West Cumberland Hospital with 4 out of the 5 consultant posts vacant and filled with locums. It's really important to remember that our model for children's services is based on what we call Sam's House. It's a joined-up approach with a much more integrated, joined-up model of care, which provides as much care as possible out in the community. The short-stay assessment units up and down the country have been shown to be able to deliver the bulk of patient care that's currently provided as inpatient, so it's really important that those work. So the 3 options that we have here, and in purple you have the preferred option indicated. The 3 options that we have is number 1, inpatients at the Cumberland Infirmary and low-risk beds at West Cumberland Hospital, so continuing inpatients, but only for lower-risk patients. The second option provides the inpatient unit at Cumberland Infirmary and a 14-hour-a-day short-stay assessment unit at the West Cumberland Hospital, but no overnight beds. And in the third option, there is no assessment unit either. It is merely an outpatient arrangement at West Cumberland Hospital, and the services are consolidated. So as I say, purple throughout this indicates our preferred options. Maternity services, this is probably the most difficult area. Many of you will be aware of the outcome of a Royal College of Obstetric and Gynecologists review. They drew in a number of national experts as well as working with local staff. And of course, their preferred option was for us to maintain consultant-led care on both sites. So we have worked for the past year and a half on how we could possibly do this. And their document made it quite clear that if we were unable to do it, we needed to move to one of the other two options. And it's with great reluctance that colleagues at the moment consider that it is unlikely we would be able to deliver that option, but it remains on the table. We're very open to further suggestions as to what we may be able to do to improve access for women, particularly from the west of the county. So there's three options there on the table. A consultant-led maternity care on both sites with small numbers of the most high-risk women moving from West Cumberland only by virtue of their need for the paediatrician, the child health support, and I'll come back to that in a moment. A second model with standalone midwifery-led unit at West Cumberland Hospital, as well as consultant-led day assessment and a gynecology unit at West Cumberland. And in the third model, providing all of the intrapartum care, in other words, the birth element of care at Cumberland Infirmary. Just important to mention, I think, and I'm sure my colleague Rick will come back to this later, that we've come up with a concept of a dedicated ambulance vehicle, a Dave ambulance that would be entirely dedicated to supporting women and children in these models. Community hospital inpatient unit. Again, I must stress this isn't about all of the functions of community hospitals. This is just about the inpatient beds. We currently have 133 beds, although some are open and closed depending on staffing levels across 8 community hospitals, with the bed ranges between 6 and 28. Lots of difficulties in continuing to provide those beds because of difficulties in recruiting nurses. 28% vacant, and in some hospitals up to 40% vacancies. Great difficulties in supporting and providing training opportunities for the nurses in those very small isolated units, and in making sure that the staffing levels are right. So in general, the recommendations are that there should be 1 qualified nurse for every 8 beds, and also there should be 2 qualified nurses on at any one time. So that gives you your building blocks of 16 beds. So we have a number of options here for what we might want to see in relation to our inpatient beds. The first one, which is a preferred option, consolidates on 6 hospital sites. 2 and 3 are very similar, but have a slightly different configuration of hospitals, which relates to either Cockermouth or Workington not having inpatient beds. And the last one would be consolidation on the 3 hospital sites, that be the Copeland unit in West Cumberland Hospital, Penrith, and a further site in Carlisle. Emergency and acute care, this was the area that the Chief Inspector noted as inadequate, largely due to its reliance on locums. So at West Cumberland, just at West Cumberland Hospital this is, at West Cumberland Hospital, unfortunately that middle grade tier, used to be called registrar tier, is entirely filled. It's populated by 11 locums. And there are 3 out of 11 consultants who are substantive, i.e. Permanent in their positions. We have worked really hard to come up with a model that can maintain acute medicine at West Cumberland Hospital, and we think we've done it. So we've come up with a model that we call a composite workforce that can replace all of that 11-tier locum, and manage that care through a different sort of workforce that is made up of advanced clinical practitioners. You may know them as nurse practitioners, but they don't need to be nurses. They could be paramedics, or they could be other health professionals as well. So training them up to be able to operate at registrar level. We've already got nurse practitioners working at junior doctor level, so we need more of them, more physician associates, and then we could have a workforce which, if it works across all of the A&E, the intensive care, the medicine department, with the support from their consultants, as well as our own medicine consultants, then we can create a workforce which we think can sustain acute medicine at West Cumberland Hospital. Really important that on both sites we do other things as well to improve care, so particularly ensuring that wherever possible we manage people during the day rather than waiting for people to become ill at nights or at weekends, so that we can provide rapid access to their GPs and to individual patients to be seen, to be assessed within hot clinics or frailty assessment units, and to make sure that we've got specialty presence in some of those really key specialties like respiratory medicine and cardiology every day on both sites. So the options here, number one, maintains our A&E and acute medicine on both sites is our preferred option. If we were unable to deliver that, it would mean an urgent care centre, potentially with daytime only A&E at West Cumberland Hospital, or at its most radical, an option which would only have an urgent care centre at West Cumberland Hospital, and therefore only step up admissions for those who are not seriously ill. Hyperacute stroke services. Hyperacute is a national term that refers to the first 48 to 72 hours after a person has suffered a stroke. We currently have services on 2 sites operating 5 days a week, supported by 1 and a bit consultants, both coming up for retirement, and a national shortage of stroke consultants. Even the most renowned hospitals up and down the land are struggling to recruit. We also know that our services are not necessarily operating to best standards, and that's because we do not have sufficient stroke specialists, we don't have dedicated facilities, and we know that the evidence shows that actually by concentrating your resources on one site, you get a much better outcome for patients in terms of survivors and independent survivors, i.e. those who are able to live without a major disability. So our proposals here are to maintain things as they currently are, with 5-day-a-week services, non-dedicated, difficulties spreading things thinly, or moving to centralise the hyperacute stroke service at the Cumberland Infirmary with early supported discharge on both sites and early supported discharge in the community, and where it's necessary to continue rehabilitation as an inpatient, that would be on both sites. Just before I go on to the financial position, if I could just make a mention around emergency surgery and trauma. There were some arrangements a few years ago which agreed that the complex and emergency surgery would be centralised on the Cumberland Infirmary site. And as a result of those changes, we've seen really quite miraculous and sustained improvements in the outcomes for patients. We have seen that even for those patients who live the very, very furthest away from Carlisle, that they are more likely to have good outcomes, including to live. So there are significant quality improvements from some of those. We have, however, looked back to see whether some of the decisions made originally on safety grounds in 2014 can be softened a little to return some of the less major elements of care back to West Cumberland Hospital. And we feel that we can return some elements, but those proposals, however, do maintain the position made on safety grounds that we would continue to centralise the care on one site without any trauma on call at the West Cumberland Hospital. Financial position. So this year, between the partners, something like a £70 million deficit between us. If we did nothing at all, that could grow by 2020 to 163 million. When we look at our plans for financial improvement, it's in making efficiencies where we see our biggest gain, by working in partnership across the organisations, only doing things once, not duplicating care, going for the best deals when we're buying equipment or supplies, and that could save up to 85 million. New ways of working, particularly around integrated care communities, preventing patients needing to come into expensive hospital facilities, could save up to 45 million. A lot of money is reinvested in the model into the integrated care communities to make them work. The clinical changes that I've talked about, 2.1 million. It's not the driver here. So this is all about improving quality at both hospital sites and right across West, North and East Cumbria. West Cumberland Hospital has been a particular area for focus. So just a slide to reinforce some points about West Cumberland Hospital, brand new facility, fantastic arrangements for being able to provide integrated, joined-up care for emergencies and for operations. So we hope to see some of the acute surgery, in other words, the emergency surgery, returning for minor cases where we think we can safely do that, as well as some minor trauma. We've already seen massive improvements. We've already got better fracture clinic presence than we've ever had before, but we think we can go a bit further, and we've been in the process over the last few weeks of doing that now. More planned surgery to take place, West Cumberland becoming our centre for excellence for planned care. Over the last few years, we've taken back 600 cases a year. We're continuing to make sure that we can take as much into that facility as possible, and that we will treat more people at West Cumberland than ever before. And as part of that, moving to the next phase of development. It's not finished yet at West Cumberland Hospital. There's more to be done to not only make a nice front entrance and tidy up all the car park, but also put in place breast screening, cardiology outpatients, vascular clinics. So I think just to finish, summing up in the messages, please remember, no decisions have been made. These are proposals. Nothing's been decided. Nothing's predetermined. We have thought that we should be honest about what we think are the preferred options. That doesn't mean that those will be the options. We have just been honest about where we are coming to in our thinking, but we want to hear your views. The options are not driven by money. What's really important is about safety and quality, and we think we have a clear vision that can deliver the sorts of safety and quality outcomes which we think you all deserve. Thank you.
Great, thanks very much. I think taken as a whole, there's a huge amount of information that you've been given there. Just to check with everybody, how many of you have actually had a look or an opportunity to get hold of a copy of the consultation document? Not many. There's boxes and boxes at the back, I think, guys, and if anybody would like to jump up and get one now, you're very welcome. I think we can perhaps even give a few out if people would like that. And just as an aide-memoire as to some of the that sounds a bit, some of the information that Debbie's just given everybody. And there is also, sorry, Elliot. Okay, I think are they both at the back, Elliot? Yeah, both versions at the back. If people would prefer a summary version, if you like, that's available too. And just, I think, if you can see, behind my head, the website there. Again, if people want to seek further information, I know more information is coming online all the time in terms of that consultation website. I'd ask you to kind of consider that as well. Thank you very much. Okay, can I hand over to you? Just in terms of kind of managing the rest of the time we got together, there's 5 main areas that are under consideration within the consultation document. If I just read those out quickly, and just a show of hands of the sorts of areas that people are particularly interested in, I'll make sure that we spend the most time on those. Is that all right with everybody? So we've got children's services, show of hands for kind of particular concerns about that, okay? Maternity, community hospital inpatient beds, okay, emergency and acute care, there's a lady in the middle who's going to be very busy, and hyper-acute stroke, okay. Say again, sorry? Okay, I'm sure we can cover that. All right, well, I think we'll start in the middle then, because I think there seems to be more interest around the kind of maternity, children's services, community hospital stuff. So could we make a start on the children's services, maternity areas? Can I ask for a first question? Lady at the front here. Could you wait 1 second while the mic comes to you? Is that all right?
Can I ask, have these, you're managing to get locums to fill the posts, but you can't get full-time workers. Have they been advertised as full-time posts, all these jobs?
Unfortunately, I'm off. Unfortunately, we have advertised many times, multiple times for posts. We've tried looking at all sorts of things which may make the posts more attractive, including reward schemes, including working in a way where we've got joint posts, perhaps with the Partnership Trust, to make neurology as an instance there where we've gone out to advertise for joint posts. We have had some success in some areas and not in others. So we have done better in relation to surgery than we have in relation to medicine. It tends to reflect the fact that there are national shortages in some areas. So if there are too many posts and not enough doctors to fill them, the doctors have basically got the pick of where to go. And unfortunately, for all the reasons I was saying before, we are just not the most attractive place for many younger doctors to want to come and to base their families. So we have advertised, we continue to push, it's really important we continue to do so. Having some certainty about where our services are going and having a clear vision for how we're going to deliver services will undoubtedly help, but it won't be everything.
Okay, there's a couple more questions at the back. Are they on a kind of similar vein? Similar vein, yes. Could you just wait for the mic? That's great, thank you.
You say you're trying to attract more doctors. The reason, surely, that they don't want to come to this area is the threat of closure of services in West Cumberland and Carlisle. And the other thing is, you're paying locums at a very high rate of pay. Can't you move some of that pay and attract doctors by passing some of that locum pay on to other people?
So we have already put in place what we call golden handshakes in those or reward schemes for those hardest to recruit to posts to try and attract them a little more financially. We need to be obviously careful about that because we've got a lot of other doctors who are all being paid on other rates. I think one of the things about locums is that many are choosing that as a career option now, and our position nationally in the country, geographically, pushed up into the top left-hand corner of England, does make it quite difficult for us. We know, for instance, that actually if we cap our locum costs and say, sorry guys, we're not going to pay you that much, and we're all being pushed to do that nationally, over the border in Scotland, it doesn't apply, and they can just go 10 miles up the road and get paid more up there. So that is difficult.
There's a lady at the back, and then there was a lady at the front.
I'm asking a question in regard to recruitment as well. Mention of nurse practitioners come in the document several times. Is it possible to be looking at a grow your own kind of policy? And are there problems with that? Financial problems?
I'll start off, but I'm keen to pass on to colleagues as well. And I think Rick particularly, and Andrew, you'll be able to comment on this, but absolutely growing our own. And we're out working with local schools, working with the nurses coming through in unqualified posts to how we can support them to go forward, working with our qualified nurses. One of the difficulties is that actually everybody wants nurse practitioners, and they are in high demand. So we need to make sure that we don't shoot ourselves in the foot by moving our own nurses around the system and just creating a gap somewhere else, but also we need to make sure that our roles are attractive enough that they don't get pulled by Manchester or Newcastle to go and take on roles there.
If you just hold 1 second, you can ask that subsidiary. Did you guys want to make any comment?
Yes, I'd just like to come in on a couple of the comments that have been made, just to support what Debbie's been saying. We, in the Partnership Trust, operate a number of services which are not under consultation, and there's no question that these services will continue and need to be enhanced. And we're experiencing very similar challenges about recruitment, and it's partly because many of the specialisms that we offer as our services are both nationally and actually internationally very difficult to recruit to. And the lady's comment about grow your own, I completely take that. It's absolutely important. The international evidence shows very clearly that if you were either brought up or you were trained in a rural area as a practitioner, you are more likely to have your career in a rural area. Therefore, it's absolutely vital that we go out to our schools and colleges. And do you know, there are schools in Cumbria that do not send kids to medical school at all and have not done so for several years. And I think that's a terrible indictment upon us as a community for two reasons. One, we're not growing our own, and we're depending upon importing clinicians and professionals from other parts of the country. But also, too, it means, where are the aspirations for our young people? Why aren't we encouraging and supporting our youngsters to think about having careers in healthcare professions? And we've been, for the last couple of years, starting to do some work on that, working in partnership with local schools, running summer schools, giving support to sixth form students who are applying to university, and maintaining contact with them after they've gone to university to encourage and support them. And that, in the long term, is what we have to do. And I would stress, in the long term, it takes 10, 15 years to grow our own, but the best time to plant a tree was 20 years ago. The second best time is today. So we need to do some planting and getting on and doing that.
Okay, Rick, a quick word, and then we'll come straight back to you. As soon as Rick's going to make an additional comment, then we'll come straight back to you.
Yep, certainly. I think just to echo from an NOS perspective, recruitment is a challenge for us. We've changed our processes in the way in which we train our paramedics now. So previously it was all in-house. It was quite a short period of time, and people moved naturally through the system, and we did grow our own all the time. Now that training takes place at 3 universities across the Northwest over 2 years, and we see 100 people coming out at the end of each year who have then got a choice of the whole of the UK. They're generally young, they've generally just lived in a city, and generally stay in the built-up more urban areas before they move on to other areas of both the UK and the Northwest. So our challenge is to attract those people to the jobs that we've got. We're doing that with relocation packages. We're also doing international recruitment, and we're also working with the local university in Cumbria to try and get placement and training done locally so we can get the local people into those posts.
Did you want to come back to us then?
One thing that's important when you go in for training is security of employment following the completion of that training, and that will be very important. Also, in training, we haven't mentioned general practice in Cumbria, and general practice has its problems and its challenges as well. And nurse practitioners can play a part in easing those problems. But for a general practitioner, what does that involve for him if he were to take on somebody who was being trained? Is there a financial difficulty or a timescale difficulty when they're studying on?
Okay. Would you?
I just wanted to say something going back to the point about the uncertainty, making it more difficult to recruit. Before we get onto your specific about general practice, I don't know, Colin, whether you can say something about this. I think yours is a training practice. I'll warn you now, and you can maybe think about it for a minute. And there is a little bit of a chicken and egg situation here. That it is definitely more difficult to recruit to a job in a hospital, be it a community hospital or in one of our 2 district general hospitals, if the service that you would be applying to go to work for is potentially under threat of change. That doubtless does put people off from going to work there. I think that is definitely a feature. However, the challenges that we have around having the right workforce long predate any of these discussions. So we've had challenges in being overly reliant on locum and temporary staff for a very long time. And now we've come to a point where this has really come to a head. And it's come to a head because of some of the national shortages in staff and because of the additional local shortages in staff. And one of the reasons why we're having this consultation is so that we can all achieve a certainty for the much longer term that will help us to recruit staff. I don't know, Colin, if you are able to just pick up the lady's point about general practice.
Thanks for the question. I'm going to take this and answer in two forms. There's the GP aspect of this, and then there's the staff who work with GPs. GPs come through medical school, and then they get chosen for GP training, and they go into the deanery system. Our deanery is over at Newcastle. We have training schemes here and in West Cumbria. Over the years, the number of GP trainees, GP registrars, who have chosen when they get into the deanery to come to our schemes has reduced. And I think last year was 0 at West Cumberland part of the scheme and just barely got the figures in East Cumbria. So I think there's going to have to be a coming together of West and East. And we're going to have to somehow convince people to choose or be allocated. And I think there is something to do with the end of the line that is the proclivity of the deanery and the Northeast mafia to not think about the consequence of year after year after year not identifying those areas that need trainees to be encouraged to make the extra mile. Because actually when they come over here, they start talking to folks, including your good selves, their attitudes change because they can see what we want to do here. And they can be at the ground floor. Instead of in the Northeast, they'll go into the establishment. It'll be the way it is. And I think there's a good case we could make to get the young GP trainees really excited about working over here. But there are a few other issues to do with the structure we have. I'm for a hybrid of general practice, from the smallest of practices to some very big practices that we're about developing in Cumbria. And I think it only works if we've got the full gamut, where people can experience the very large practices if they so wish, and can also go to the small practices if they wish, and that we support all of them within our integrated care communities. So I would hope in the future, with this new plan, we'll be able to campaign together at the deanery to get a stronger, unified scheme here and get more people coming over. I think we have to overcome the proclivity of the millennial group of folks who there's nothing wrong with. I've got 3 children in the millennial group who make and think completely differently. As if you watched my conversation with them, you could see the generational gap is very frustrating. And my daughters have made certain decisions that I kind of remonstrate with them about, and they kind of quietly tell me to get lost. But eventually the millennials will make a journey of finding themselves. And when they do, they'll want to find themselves back at home, a lot of them. And the question is for us, are we ready for them when they decide that Cumbria is the best place to be? And I'm not so sure that we are yet. And we should make more common cause and not see ourselves as general practice and mental health as mental health and community. And I think integrated care communities will allow these folks to come and train in an area where they can have experience of all sorts of things. They could be in A&E, they could be helping out the mental health team, they could be in general practice, they could be helping out in maternity services. And we should respond to that rather than saying, here's one size fits all, you've got to fit in there, and if you don't, then I'm sorry, can you go somewhere else? I think it's a two-way thing, and we've got to find out what makes their career work for them. And that's a reflection not of how selfish these people are, but of how they have come to think about how they have the maximum effect for themselves in what they do. And that's a very complicated thing, because when my daughters talk back to me, they say, you're trying to fit me into something, I don't fit there, and you're going to constrain me in what I can do. And I say, it's just how the job is. And none of my daughters are going to be doctors. And quite frankly, they said, we're not going to do what you did because look what it did to you, sort of thing. Not in a bad way, but I think they watched how my life was molded to the job, and they said, there's no way we can work like that, Dad, no way. And because that's what you did, that's what I signed up for, folks. I knew what I was signing up for. This is not a complaint, but my daughters, they wouldn't do it. Not a chance would they do it. Coming to the other staff training, sorry if this is very long, we have to learn how do we get out of this idea of who employs who. And I think one of the problems we've had in general practice, we've been small units. We train a nurse practitioner. It's great. She stays with us for 2 years. It's a massive investment for us. And then off she goes. Why shouldn't she? Somebody's just offered her £15,000 more and a better working life. You know, she's got a house, a dog, 2 children, a car. I can't blame that nurse practitioner. Yes, you can have deals about people staying for a while, but inevitably, it's not just nurse practitioners, it's everybody. So you can't complain. Once folks get extra skills, they become a better economic unit for them and their family, that they then exercise their right to have a higher status job in the sense of pay and conditions. So we need to work with in teams across North Cumbria and show how there can be career progression. And there's something that you said, how do they know they're going to have a job? But they not only need to know a job, they can have to say, what if I want to go on in this? Where do I go? And we'll keep them because we give them jobs that grow with them, not only in status, if we can use that word, but in the way they feel they can do the most. And I'm not only for nurse practitioners, but ambulance practitioners, for key workers in mental health, for folks who may be doing physician's assistants in hospital. That's a rather long answer. It's a very complicated area, but I think we need to work together. And this is actually when we get a chance to say to you, not only will it have to be what we do, but I think it will have to be communities that will do this. I went on holiday to Alberta in Canada. I was standing in a line. In front of me was a recruiter for general practitioners in Medicine Hat. He found out I was a GP and my wife was a theatre nurse. He was trying to recruit us to come to Medicine Hat, right? He wasn't employed by the health service in Medicine Hat. He was part of a volunteer group of people in Medicine Hat who decided they wanted to go and find doctors and nurses to come and work in Medicine Hat, Alberta. And I thought, we don't have a hope of finding docs. Here's this guy standing in an aircraft line trying to recruit me to Alberta. We don't have anything like that here. And I think, therefore, and I know Alwyn yourself would be only too happy to do this, we must find how we bring our communities into being part of the recruitment process. Thank you.
Okay, I think that was a fairly comprehensive answer, wasn't it? There was a lady down here, but just before we do that, I think a gentleman's just come into the room that probably warrants an introduction. Sunil, would you just stand up and perhaps identify yourself, as they say? Good afternoon, everyone. And could you say who you are?
I'm the chair of the programme board for the success regime and therefore have a lead responsibility alongside the clinical commissioning group for the production of the clinical strategy which we're talking about today.
Thanks very much. Okay, I think it was a lady down here who had the next question. Could you hold on 1 second, and there's a microphone coming.
Thank you. Part of what I was going to say has actually been touched on, but a lot of these courses and training that is done by the hospital or by people to enable people to be healthcare workers, doctors, nurses and everything is very expensive and can take a long time. And I don't see why when a doctor, say, for instance, has the training for all that time, why they are not committed and have to, by law, go to hospitals, and at least then you are guaranteed to have a doctor straight out of newly trained for a short time. You know, this happens in other countries. Why can't we do it here? And in that case, they could be allocated to the hospitals and move around 1 or 2, and we give them a little bit of choice, and perhaps they would want to stay here. But the other thing is with the homegrown things, it's a long time ago, but I joined the NHS and I was homegrown trained. And when I did this, we were all homegrown trained, and we all practically stayed for years and years and years. And when it stopped, it went. People came and went, and now you wouldn't know who was there last week, next week or anything, because the turnover is horrendous.
Debbie, do you want to make a quick comment? I think you already said briefly about the incentive that is available to make people stay, as it were.
Yes, we've looked at what you're talking about in terms of whether you can actually keep people after their training. It's something we're continuing to pursue, because you're quite right, in other countries, but also in this country, in other professions such as in the army, in the probation service, that is exactly what they do. I think what's important, and we will continue to explore how we can manage to hold on to people where we've invested in training, and we're certainly doing that around the acute medical workforce. We're working with the deanery to have some trainees for some of these physician associate and other posts where they're taking on new roles previously done by other health professionals, to have them especially earmarked for us. We're investing in it, and we then expect them to stay. So we are certainly pursuing that. What's really important, though, is that we can retain those after that short period of time, because you can't hang on to people forever. And what we want is for people to want to base their homes, their families in this part of the country. And we feel that giving a really strong vision about modernised services that are fit for the 21st century and deliver the best outcomes is actually what will attract people most to come to this part of the world. They won't be attracted by old-fashioned services which are not moving with the times.
Okay, we've talked quite a bit about kind of workforce issues. Is there another area you'd like to move to, or do you have any further questions about that? Shall we? Sorry, is it?
My question would be about elderly care.
Okay.
So if you want to move people back into the community, and which is sort of this ideal thing, isn't it? But so therefore you would be saving money. But then social services reckon they have no money. Now, I worked in social services, and believe you me, every year we were told that it's no money. And I know that since I retired, the situation has got a lot worse. And a lot of people living in the community, they're not getting the full care that they need. So if you're going to have all these people coming out from cottage hospitals, there are obviously going to be changes with the homes in Carlisle, and that's going to be reduced to half the beds. Not everybody has family to look after them, to see to them. And I think this is going to be a huge problem, as is, of course, bed blocking.
Okay.
Because I've experienced, I had needed an operation early this year. I chose to go to Whitehaven because there were so many bed blockers at Carlisle.
Okay. Peter, are you happy to pick that up?
It's a really important question. So we're at a point where health and social care services need to really be joined up in a way that they perhaps never have been in the past. And there are lots of ways that we're working with our colleagues in social care to try and improve exactly the situation you described. So some really important things. We need to find much better ways to support family carers and other carers in the home, because the truth is, if it wasn't for the enormous amount of work that people's own families do to support their loved ones, then our National Health Service would be in a much tougher place than it is. So that's very important. A second area is that some fairly modest changes in people's homes can make a big difference. Even things like grab rails, so simple adaptations to the home environment can really help.
But I'm talking about people who maybe can't walk well, or as people get older and become more frail, it's not suitable for them to be at home.
Okay. Everybody here, the lady's asking about, she's thinking the homes that are being planned, are they suitable for people in later years? Is that what you're...
Well, no, you're saying that you want people to stay in their own homes, and it's an ideal situation. But some people, there are a lot of them who just simply are not fit to be in their own homes, and therefore would be gravely at risk in their own homes.
So just picking up that point specifically, I think we know most people would prefer to stay at home for as long as they can. And addressing the financial point you made, residential care is actually very expensive. And there are ways that we can support people to live independently at home, particularly, for example, after someone's had a nasty fall, or after someone's had a nasty fall, or if they've broken a bone and so on. We can find better ways to support people's recovery so they can live independently at home for much longer than they currently do. And that also has a benefit of saving money, because residential care is very expensive. So in a sense, there's a win for everybody here. If we can support families to look after their loved ones, recognising how much of a challenge and how difficult that can be, if we can support individuals to live as independently as possible for as long as they can, then actually there is a financial benefit too in terms of the cost to the taxpayer. So if we can get this right, it can be good for everybody, notwithstanding there will always be some people who will require residential care for the reasons that you've said.
Okay, I think... okay. Andrew's going to come in. We're going to stay on community beds for a little while after this. So if you've got a question around that, if you can just kind of get it ready and let me know, and I'll come straight to you, sir.
Yeah, I just wanted to add a couple of things to Peter's answer, to talk a little bit more about what actually health services, along with social services, can do to help in this issue. One of the things that Debbie talked about in the opening presentation was the development of integrated care communities. And they will be the way where healthcare and social care professionals get together and look after the care of their community. And part of the vital work that they will do will be to look at the health and well-being of the whole population to prevent people falling ill and people becoming infirm and needing to come into hospital in the first place. And they'll have two important roles. One is promoting well-being, and the second will be maintaining health after people have recovered from a period of illness. When Beveridge wrote the report that launched the welfare state and the National Health Service, he talked about the great scourges to well-being. And I think if we modernise that report, the two great scourges for public health and well-being at the moment are inactivity, people not getting out and doing very much and getting exercise, and isolation, people being lonely. And one of the tasks of integrated care communities has surely to start to find ways of enabling local communities to overcome those two great barriers to health and well-being. And the second task, as I say, is when somebody has been ill and needed a period of hospital care and they're coming home, to help them and their carers develop a plan that will reduce the chances of the person falling ill again. And we know there is a huge amount of science now available to us to do that. My brother, heaven help me, unfortunately paid the price of some of his bad lifestyle choices a few months ago and sadly had a heart attack, from which happily he has now recovered. But he has a great, huge, long list of things that he can do to improve his well-being and overcome the inactivity that led to his being ill in the first place. And happily, his outlook is now really good. And that's the kind of work I see integrated care communities coming together and supporting people to do.
Okay, I think the gentleman there wanted to pick up on the inpatient beds.
Yes, my name's Graham Higginson and I live in Carlisle. I don't work in the health service or have any official connection with it, as many people here do. I'm a volunteer with Age UK, but I don't represent Age UK. What particularly concerns me is the issues that you're now talking about on integrated care. And it's as though we've suddenly discovered something, some wonderful panacea. Now, all this has been known for very many years. My personal interest in bed blocking and community care arises from the fact that my wife, several years ago, was recruited by Age UK, or Age Cumbria, as it was then, Age Concern Cumbria, as it was then, to commence a hospital aftercare service in Carlisle, which she and a small number of other paid staff did, and it was operated through volunteers, and it was very successful. It gave a great deal of support to individuals that needed it. It was appreciated by the medical staff in the hospital that understood its role and so on. And then all of a sudden, Cumbria County Council decided they weren't going to fund it anymore. And it was swept away. And then years go by, and somebody thinks, wouldn't it be a good idea if we had hospital aftercare and to prevent people going back into hospital? And so along comes another agency, I think, in recent years, the Red Cross Service, to offer a similar function. And then the hospitals also have reablement and this, that and the other. The City Council discovers that it needs to have a role in looking after people in the community. We have the care line issue and all these kind of things. So people are doing lots and lots of things around in the community. It's not being integrated, and it's all being swept away. You're talking about integration, but you can't even these days get an appointment with your GP easily and without going through a whole string of questions from non-medically qualified staff. So I don't see that all this brave talk of the wonderful integration that's going to solve all these problems is any more than wishful thinking.
Okay,
and I'd like to know, really how you are going to achieve any of these wonderful things which you say is the object of this consultation exercise. Thank you.
Okay. Debbie, do you want to?
I'll kick off, but no doubt other colleagues will want to come in here as well, because this is so fundamental to our proposal. So you're absolutely right. This isn't new. This isn't rocket science. This is something that people have been talking about for many years. And locally, we haven't managed to deliver it. There are other places in the country that have managed to deliver it, and other places across the world that have managed to deliver it. And we have been building on the evidence and the learning from those places, bringing in some of their experts. So they've been very successful in a part of Devon in this area, and we've had an expert from Devon assisting us with our plans. I think one of the things that we need to think about is why it hasn't worked in the past. And one of the biggest reasons why it hasn't worked in the past, when we've all been talking about it, is because we have not been all on the same page in terms of our leadership and where our incentives are aligned to match up. So whilst in the past our leaders have been able to say, yes, that's what we want to do, when the goings got tough, it's been very, very easy for them to go, oh, well, actually, yes, it sounded nice, but no, we need to make a cut, so we're cutting it. We have not only a plan now, but we've got the agreement locally for how, at a leadership level, we work together to share our leadership, share our risks, to make some of this happen. And I think that's the most critical lever that we have. It's reflected nationally to a certain extent in what are now being called the SDPs, or Sustainability and Transformation Plan patches, which are up and down the country. But the whole point of that is that rather than organisations acting in isolation from one another, and when the going gets tough, making a decision which is in the best interest of their own business, but not of the wider population, now we have a move to actually make those decisions together and consider population health and well-being, and not just what it means for individual organisations.
Okay, Peter, do you want to say a quick follow-up, and then we'll come to the lady in the middle?
I'll maybe say something about the point about access to general practice. So I'm guessing probably everybody in the room has had, at some point, for them or their family, a frustrating experience about trying to get access to their family practitioner. I certainly have. I guess one of the big challenges for general practice now is how people can gain access for the right service at the right time. So historically, and there's at least one GP in the room now to pick this point up, but historically general practice booked appointments for 7 to 8 minutes for a consultation, as if we all needed a 7 or 8 minute consultation. Of course we don't. So sometimes all we need is a repeat prescription, Sometimes all we need is to find out when our appointment at the hospital will come through. Sometimes we just need to find out if our blood test is back. And sometimes a 7 or 8 minute consultation isn't enough. And there's a really challenging or complicated health issue that needs much longer than that. So I think one of the things that lots of the practices are doing is how can they get the right information from the patient to get the right intervention so that people can get the right service as quickly as possible. I think that's why some of the practices are using these kind of approaches of explaining the history, explaining what you're asking for. Some practices are already working on, you always speak to the doctor first before you get an appointment. So there are different approaches that practices are taking to try and get that right.
Okay, there's a lady in the middle, I think, had a question.
Thank you. Can I just endorse what the two members of the public on this side of the room have actually said and really urge that you do listen to them? Because I've said it before and I'll say it again. The problems of Cumbria are historical, right? None of this is new. It has been allowed to fester and fester for years. And we're in this situation not because of the public, but because of our leadership, right? Our management, and the fact that it seems in Cumbria we're just not accountable to anywhere because we're so far north and we're just left to get on with it. I want to endorse what this gentleman said about the aftercare and the volunteers. Around the same time, we had some funding into the voluntary sector for what we called community champions. And these were people who willingly did not want paid, but were happy to go out into the community, to community centres and other places to actually make people think about the lifestyles, about risk-taking, about the families, and about moving their lives on. Again, the money was cut. Now I see that the county council are going to pay people to go and do that at up to about £30,000 a year. We have to start looking more wisely at how we spend our money in Cumbria. The other thing I want to say is about, like that lady said about the high elderly. We have a higher than national average of an elderly population and have had for a long time in this county. It is growing. I heard this morning that by 2020, 25% of our people in Cumbria will be over 65. Now, not because you're over 65 does it bring infirmity and serious long-term illnesses, but it seriously can, and it makes a big impact. And these are people that, as they've grown over the years, they've done what the government of the day has asked them to do, and now we say we can't afford to look after them, which I think is really criminal. But the thing is, integrated care in the community, we were going down that route when we had the closer to home consultation between 2005 and 2007. That was never fully thought through, and since then we've actually grown more long-term conditions in this county. So again, like it's just been said, it's not rocket science, but really, we really need some strategic thinking in this county once and for all. And what should have happened here should have been a deep dive and a whole systems review. And all we're trying to do here is paper over the cracks, telling people we're going to put care in the community. I don't know where we're going to get these people from. Thank you.
So would you like the panel to respond to that in terms of, you talked about leadership, you talked about kind of historical matters, we've been here before, you talked about a previous consultation and what happened to that. Is it all of that you'd like them to respond to?
I'll leave it up to you.
Would the panel like to respond to a question about leadership? What this requires is stronger leadership. You all right with that?
I'll start. I'm sure I've got colleagues who will want to come in. Just something to be said about leadership. Leadership isn't always, of course, about holding tight and telling people what to do. Sometimes it's about letting go, letting the people on the front line who know the services best determine what's right for those services, letting the people who use those services, patients, carers, families, inform how we design services. And I think that that's where the difference in leadership needs to come. So it's about ensuring that we can use the resources that we've got, not just about the chief executives, but about the entire teams made up of clinicians working with our communities, and something we haven't said very much about on the panel, although it's been mentioned from members of the audience, about a new partnership with the third sector, which I think that we haven't made maximal use of, and we have so much to do there. And it's always very difficult even in the consultation document, which is long enough, to get across how important what we are terming co-production is. In other words, that we design our services, that we improve the ways in which we do things, not just between the organisations, but with members of the third sector, volunteers, charities, and particularly with patients, their carers and their families.
Gentleman who came into the room a little later, Sir Neil, I think might have something to say about leadership of the programme, given that he's a leader in the programme.
Thank you for the opportunity to respond, and let me say I'm delighted to be here this afternoon. I'm sorry I couldn't be here at the beginning. I'm spending the lion's share of my time at the moment traversing West, North and East Cumbria, listening to people such as you about the ideas we have and getting your thoughts about how we can make our plans better. The point you make about the past and history is really important. I applaud the leaders in West, North and East Cumbria for the sterling work they've done, and the clinicians, sometimes against very, very difficult odds. I think, though, there has been perhaps a sense of, well, we've been there before, we've tried it before and it hasn't worked, and I'm not saying that people have given up, but there's a sense in the past of people feeling dispirited. I actually believe there is a team of people in this part of the NHS, and I spent all of my career working in the NHS up and down the country. There's a team of people in the NHS here who are more than capable of leading and implementing these changes. What we're offering is certainty. We're offering, through this consultation process, the chance of more certainty about the future of health services and all of their parts than I think has been available in the past for many, many years. And I ask you to think carefully about your responses to the consultation, which actually, you talk about a deep dive, and I've just come in and listened to the discussions about integrated care communities and community hospitals. Those of you who've had the chance to read the document will see it embraces all of the services that are provided. It doesn't give all of the technical detail, but that's available. That is available on our website, and mental health consultation is due to follow before you raise that with me. Again, I absolutely understand your point about that. There's never been a shortage of plans in West, North and East Cumbria, but there hasn't been a sense of real grit, determination to pick them up and make sure they're implemented. And Debbie's absolutely right. This time, we're going to make sure that plans, whatever the outcome of the consultation exercise is, the plan will be implemented. And I think it's worth just thinking about the closer to home strategy that was consulted on a few years ago. At that time, primary care in the NHS in Cumbria was deemed to be leaders in terms of what we now call integrated care communities. And I don't know why that plan lost its way. I think I understand some of the motivations, but it wasn't through a lack of leadership. There were circumstances, political and other reasons, policy changes nationally, that militated against the ability to deliver that plan. I'm absolutely clear about that. But now we have the chance to do something really powerful, something important, something meaningful, which I am convinced will make sure that services for the people who require the NHS in West, North and East Cumbria will be able to avail themselves of some of the best in the country. In fact, some of the best internationally, because that's the extent of our ambition and our vision for the future.
Okay, just a time check. We've been kind of going about an hour. Would people like to stay on the beds? Would they like to move to children's and maternity? What's the kind of feeling in the room? Let me ask what your question's about. And then I'll come to you.
I'm a GP locally in Wigton, and I have read about and hear the term integrated care community over the last few months as being the solution to our problems. And Debbie Freak referred to integrated care communities as being fundamental. I'm still really mystified as to how they're going to work, their structures, what will be different for patients, and really I have a great deal of skepticism that they will be the answer in future.
Okay. Which of the panel would like to pick up, are they actually going to work?
I'll take that one then, shall I? I think just building on what Sir Neil was saying there, one of the things I would say is that a system delivers what it is designed to deliver, by and large. And what we've got at the moment in Cumbria is an opportunity to create a different kind of system. The system that we've had up to now is one that has been imposed through, well, amongst other things, the Health and Social Care Act, which determined that organisations should become more efficient and should become more effective through the means of competing with each other for short-term contracts. And that's been part of the problem that led to what Graham referred to earlier with respect to voluntary organisations not being able to plan far ahead because they were only given a contract for a year at a time. What the success regime is allowing us to do as healthcare providers and as commissioners of healthcare is completely change that so that the premise is no longer about organisations competing with each other for diminishing resources, but actually professionals and organisations working together in joined up groups, actually with their own budgets. And that's one of the things, if ICCs are to work, they've got to have control over resources so that they can make the decisions about which voluntary organisations in our community are providing the services that we need, how can we support them not just next financial year, but in 2, 3, 4 years' time, so that they've got the people with the skills that are needed to keep our population healthier and at home for longer. And I think the questioner here is absolutely correct. Nobody has actually come down from on high with a blueprint as to what the ingredients are of an integrated care community, what exactly they should do, but there is a clear commitment that they will have control over their own budgets, they will have opportunity to think further ahead than the one-year planning cycle that we've been allowed, and they'll have a very clear mission to promote the health in the wider sense of the populations that they're looking after. And actually we're in early days designing that. As Debbie said before, we know an awful lot from other places as to what the ingredients are that enable them to work. And we also know that about what they have to do to be successful, what the signs of success would be. And for me, one of the most important signs of their being successful is that patients come into one system and they don't know who the person is working for because they could be working for several different organisations, but they all know that they're working for the National Health Service in their community and that their job is to get them well and to keep them well.
I'm going to ask Peter to say something, and I'll ask you if you want to come back, and then I'm going to come to you, okay?
I think, Colin, you want to address this point?
Hello, John, fellow GP. You might remember in my previous comments I said that we are going to have a hybrid response because life in Wigton is not the same as life in Carlisle, and to pretend that your practice and group of practices in your sub-locality of Allerdale around the Solway Plain is the same as urban Carlisle in history terms and in the way that you practice would be cruel torture for us all, either trying to apply a Wigton answer to Carlisle or a Carlisle to Wigton. In fact, even in urban Carlisle, I think there will be different solutions for different practices in urban Carlisle. we're probably going to have one large merger and then maybe a federation of other practices. We don't know yet. So this brings us around to how do I know what's going to work? And I can only take us back to the only other time that I can think that we were launching into an unknown, and that was the beginning of the out-of-hours doctor service. And in fact, you and I may have been in the same room. You probably in the audience, me up at the front, giving you big promises, and you saying you're going to hold me to account on that matter. And the big issue was, how could 50 practices, 50 ways of people getting out of hours calls suddenly be tackled with one call centre, and wouldn't that call centre be overwhelmed? And what would happen with people who had specific problems? And really the answer was, we are going to address these problems if we together undertake to do that together. But if I had stood up there and said, there's the answer, it's easy. I think I did say there's the answer, but actually we'll review it in a week-by-week basis and change it. And 20 years have passed, and I think that most people now understand the system. But I think it grew out of that commitment that we should do it together rather than do it separately. And the way that we tackled each problem, like folks in nursing homes or folks in palliative care, or folks where we might have thought that behaviour, mental health problems would be a problem if they weren't being dealt with by their own practice. How would the practitioner know about that specific issue? And we developed a special patient's note to try and help. Is it perfect? No. But I think we are going to be here dedicating ourselves to a system that will never be perfect, that we're continually going to have to be talking about. So again, what I'd be saying to in Carlisle here, the large merge practice is going to commit itself with the community trust, with the acute trust, with social services, to make that journey. It's going to have to include its patients. It's going to be bumpy, and I would say this, if all of us, I mean me, the practice manager, those who work in it, and all the patients are not outside their comfort zone, we have not been traveling where we need to go. And I think what really has to happen for me is, and this is because we're going into a large merger in Carlisle, I have had to be challenged about my consulting life, my surgery visit, admin, surgery, clear up, surgery life I've been having for 27 years. And in the last 2 weeks, somebody has had the audacity to come along and say it could be different. And some of my patients don't like that, and we could get them all up here telling you why they don't like it. But if they don't like it, neither do I. But one thing's for sure, it has demonstrated to me that there are many ways to skin a cat. And because I did it for 27 years the way I did it, it doesn't mean it always has to be so. And for instance, I have watched how the way I'm doing visits has become more efficient. The way certain patient groups are able to access services regarding home care because of the home care team we can have now that we're larger that we couldn't have had before. The way we're able to have one practice being the urgent care centre for the afternoons and those who want to be seen in the same days. Is this perfect? No. Will we have to work on it? Yes. And why are we doing this? We're doing it as our part of preparing to be our part of the integrated care community. So what we're hoping is if we align this way, when we come together with our colleagues in the community service and the acute trust, the ambulance service, etc., we will be sufficiently robust to be able to play our part, and that is very, very difficult. I would like to take an ambulance example. For instance, the Pathfinder example, where if the ambulance paramedic is at home with somebody, they could speak with a GP quickly through a particular system that CHOC actually helps us with. Another way that we have to have all elements working together. And then if we reply quickly, we can have a conversation with the paramedics. And we have had hundreds of thousands of journeys to A&E stopped because that conversation took place. And I think that that demonstrates that we are not talking, we're talking huge numbers here of people who'd have to be taken to hospital. And you and I know that once in the A&E department, by no fault of the A&E crew, they are almost by a huge magnet drawn into hospital and can't get home. And I think that also the issue here is how little things start and they're not dealt with and they become big things. And I think I understand the fear that people who are very vulnerable and have could very quickly become very unwell to their detriment. But I think it's because we don't get the little things as early as we should. And I think that if we set a system up where those little things could be seen, I often see somebody, they say, the doctor must come, and I go and see them and say, well, if I'd seen this person a week ago, I could have done something, but now I'm going to be admitting them to hospital. So I could go on, as people could probably imagine, with examples of how these little things, and again, if we go to the British cyclist team about how they became so good, it's 1% of everything. And I think that you could sit and go, 1%? Oh, come on, Dr. Patterson. It doesn't mean anything. But if you do it 100 times, it's meant a lot. And I think if we commit to that process of continuous improvement, you may think I'm a dreamer, John.
Okay.
But I think we can improve things.
Thanks very much. And if it hasn't answered fully, we can come back to you. But there's a lady over there that's been very patient. So can we come to you? If you hold on 1 second, and apparently we need you to speak into the microphone a bit closer to you.
Oh, thank you.
Thank you very much.
Can you hear me? Oh, yeah. Basically, I'm just going to give you a scenario. Say, for instance, a patient has a stroke and they end up in Carlisle Hospital and they're fine medically, but obviously they need physio on their arms and legs to be able to function correctly at home. Where do they go after that? At the moment, they go to community hospitals, but obviously you're closing those beds down. And they can't go home. And obviously when they go home, they'll want social care in carers coming out. But at the moment, it's very, very difficult to get carers in this rural location, especially overnight. There is quite a few weeks waiting list to actually physically get a patient out of hospital into their own home. And also, who pays for the home care? Is it the social budget or is it NHS budget?
Okay, so something about community services, Andrew?
Yeah, I'll take the component about where people move after they've received their acute care. Every healthcare system has a range of different types of bed-based services. We're familiar with the services provided in acute hospitals when we're acutely ill, and we need a great deal of technological intervention. We need people with very specialised skills and people with access to specialised equipment. And it's recognised in every system, and ours is no different, that when that need has passed, there may continue to be a need for the person to have a form of bed-based care. And that step-down function is what our community hospital beds are doing, and actually what they will continue to do even after this consultation. All of the alternatives that are being put forward envisage that step-down beds in community hospitals will continue to be provided. Some of the community hospitals will have their bed numbers increased because, as Debbie said in her presentation at the beginning, there is a need to provide community hospital beds in multiples of 16 so that we can effectively use our nursing resource, which is very precious, to its full capacity. And 16 beds appears to be the minimum number that allows us to do that. And our community hospitals that have their bed numbers reduced will continue to provide a base for integrated care communities. And when people do no longer need bed-based hospital care, then some of the rehab functions and daycare services that they'll need will continue to be provided in the community hospitals. Some of the rehabilitation services that a person will need, as they do now, will be provided at home as well through physiotherapists, occupational therapists and other therapists and nurses visiting the person at home. And there'll continue to be a need for other forms of bed-based care. Actually, the largest part of bed-based care is within social care resources in residential care beds and nursing home beds. And they'll continue to be provided as well.
Was part of your question about how the care is going to be afforded as well? So I don't know whether that is something you can comment on.
I'll come to you specific, but I want to say something more broad about stroke, if I may, because I think it's a good example of what we're trying to achieve here. So we know that when people have a stroke living in our part of the world, that altogether the outcomes for those people are not as good as they are in other parts of the country. And that's one of the reasons why we want to bring together the inpatient service for people over those first critical 72 hours of care after a stroke into one place, so we can have the best possible clinical teams with very regular nurse observation, very regular doctor observation and so on. So that's a key part of the proposal in terms of the service change. We also know that there are lots of people who have a stroke where it could have been avoided. So there are known risk factors that elevate your chance of having a stroke, and there are interventions that can help to prevent that. So for people with hypertension, so blood pressure problems, people with atrial fibrillation, which is an irregularity around how your heart functions, there are a number of issues that we know if we provide better care in general practice as part of the integrated care communities, we can actually reduce the number of people who have a stroke in the first place. And before that, Andy was talking about some of the broader risk factors, about diet, about movement, about social interaction, which also really reduce likelihood of stroke. So we want to reduce how many people in North Cumbria, or West, North and East Cumbria, for the whole patch, are at risk of having a stroke. If they do have one, we want them to receive the very best care they can over that critical 72-hour first period. And then we want to support people to go home as soon as possible. And part of that will be about how we can have early stroke supported discharge, so people can go home safely, knowing that physiotherapists and other therapists will come to their home and help them with their rehabilitation. And also that home care, social care home care, can be provided, particularly to help with the practical issues of the impact of a stroke. On your specific, home care is social care responsibility, meaning Cumbria County Council, so that element is not funded by the NHS. Thank you for your question.
Rick, did you want to say anything about the stroke reconfiguration and how the ambulance service is playing into that? I'm just conscious to involve you in the conversation a bit more.
Yeah, certainly. In terms of all of the pathways, we're working closely with our partners, especially with stroke, with ED, with children's and maternity, to look at what we need to do to make sure that we have the facility to be able to encompass the transport needs for any patients within that system. And I'd certainly echo the hyperacute, the better outcomes. We've seen that already with the transfer of seriously ill patients from trauma and the outcomes that we have from taking those patients to specialised units. So again, that replicates across stroke, and in terms of transport, we're making sure that transport element of the whole system works as it should do and as one.
Okay, there's a lady in the middle. Are there more questions that people are still kind of sitting on? That's good. Okay, I'll come to both of you guys after this lady here. Lady in grey, just next to you.
Thanks. Peter, you've touched on what's known as a prevention agenda, haven't you? Now, again, we have a lot of work to do in Cumbria around prevention. We have the observatory that gathers statistics, and we have the Joint Strategic Needs Assessment, which varies from area to area and county to county as to what's measured. If you really are serious about a prevention agenda, not just for strokes but for other things as well, maybe that's another consultation that we need in Cumbria, because this is where the county council and with the public health department and the observatory and the local communities need to be coming together as to how we actually engage with our young people to stop taking risks. There's an educational need there as well. And I think if you really want your integrated communities to work in time, you've also got to have part of that, a serious, meaningful prevention agenda. And we ain't got that either. Thank you.
Okay. Did anybody want to comment? I don't know whether, Sunil, you want to comment on the role of other organisations that are kind of part of the partnership but not necessarily here today, about that role of the local authority in terms of that prevention agenda?
Yes, just a word or two about that. The principal partners who've been leading the development of the future of healthcare are here and have been referred to earlier. The local authority are critical. We've talked about social care, but also their responsibilities in terms of public health, which will be the driver for the preventative strategies. But there are so many others as well. We have been impressed by the contribution of independent sector, third sector organisations, and their contribution also. There's a really important point, I think Colin alluded to it earlier. Whatever is ultimately decided that we should do, it's essential that all of us pull together and put our shoulders behind the outcome of consultation to make it work. The NHS can't do this on its own. It can't do it on its own with even the local authority. It has to work assiduously with third sector, independent sector organisations and the public. We have to get a real strong sense of a social movement behind whatever the outcome of consultation is, because it's only working together that we'll be able to create the kind of environment and the high standards that we espouse to within this consultation document. Public health have been intimately involved, and a hobby horse of mine in terms of prevention is, wouldn't it be good if we could just make sure that the interventions, you talk about consultation, but we know about the interventions that already work. Peter mentioned some of them. Well, how about focusing on really reducing smoking? Well, how about focusing on smoking cessation to such an extent that we've become the best part of the country in terms of reducing smoking? If we were able to do that and the interventions are well tried and tested, my goodness me, we'll make a big impact in terms of preventing ill health.
Okay, there was a lady here and a gentleman. Perhaps the lady first.
I just wonder, have you had the results from the Times and Star that everybody did the questionnaire about? It's been in for about a month, and apparently they've had thousands of replies.
I think the answer to that's fairly straightforward. We know there are various respondents preparing their comments. There are petitions and all kinds of arrangements. We won't receive the outcome of all of that until consultation is ended, which is before Christmas. And if we haven't explained this, and forgive me if this was said before I arrived here, we are employing an independent organisation to analyse all of the comments we receive, to give the CCG the kind of, I suppose, forensic view of that which people are saying, so they can then make decisions. So we're a little way off that.
So if it comes that sort of 90% of the people, the thousands that have said the reply in, and 90% say against, are you going to go back to the drawing board?
Well, I think Neil might have answered the question in a way. Do you want to say a bit more about the decision-making process?
Yes. I don't know, Peter, have we talked about this in the earlier
Debbie
presentation?
covered it briefly in the presentation, but
Okay.
I think the point about, is this a vote of everybody, I think is a good point.
It's a really important point, and there's a paragraph in the consultation document that says that. It's not a vote, it's not a referendum, it's a consultation process where views are received and assessed and listened to, and responses have to be made as part of the CCG's response and ultimate decision-making process. No one has a power of veto, and it's important that we take account of the multiplicity of contributions from members of the public, but equally, it's important we listen to the views of experts from the national medical colleges and the local clinicians and lots of other people as well. So it's quite a complex issue, and it's Peter's responsibility, with our support, not him personally, but his CCG's responsibility to demonstrate that proper consideration has been given to all of these views. I don't know, Peter, whether you want to...
Are you happy with that answer?
Not really, because if you're asking us and 90% say we're against it, well, why ask us?
But I think...
Well, there's nothing more I can say. I mean, I promise you we will listen to the views, all of the views that are received from members of the public. But we have to weigh those views with the views of lots of other interests, including, as I've said, experts. I'm not saying that you're not an expert. I dare say you and your family have had lots of experience from health services, and to that extent, you're an expert. But we have to weigh up all of these views and take them into account together. And we can't start saying now, before the end of consultation, well, we've heard about this 90% view from Workington and somewhere else, therefore that is the view. We have to give everybody the opportunity to be able to express their views and think of them all in the round.
I think elsewhere we've heard the kind of consultation responses that you've had to date, and they've been quite considerable, haven't they? Did I hear something like 900 already received?
I don't know how many, but they are significant. And you know what I'm really pleased about that? It would have been very, I use the word dispiriting earlier, it would have been very dispiriting if we published this consultation document and launched it, and when we hardly had a murmur from anyone. I never thought for one moment that would be the case. But the fact that you people and so many others are so keenly committed and interested in your National Health Service that you go into the trouble to respond to this consultation document, I think is very important, and it's a powerful sense of community that we need to build on.
I think Debbie wants to say something, and then I'll come to you, sir.
I just want to say that I think it's really important. Again, we've touched on it. I spoke about it, Colin spoke about it, Sunil's spoken about it. It's critically important that we don't view consultation as a once-in-a-lifetime opportunity to make feelings felt. It's really, really important that we actually develop a relationship with our staff, with our patients, with our communities, with our carers, with the third sector that we perhaps haven't been very good at before, one that is continually listening, responding, reacting, and that we have this dialogue that goes on. So in the engagement phase, there's been, something like 140 meetings, 800 responses, 86 different locations, and that has meant that we have been able to listen to some of the views in coming up with this consultation document, that it has significantly influenced what has gone into our very detailed proposals. And importantly, after the consultation, whatever the outcome is, it's absolutely crucial that that dialogue just continues.
Okay, there was a gentleman here, I think, was next.
I have two questions concerning the acute hospitals, which have actually been in the national news as being one of the most financially strapped trusts in the country. If we take the old PCT spend on the acute hospitals in 2007-8 as a baseline and then add 4% a year for NHS inflation, we know what the hospital's income would need to be just to counter inflation. If we look at that against what the acute hospital's actual income from the PCT and CCG was, we find that the acute hospitals are 107 million short of break-even against inflation in just the last 4 years. If we were to use the Institute of Fiscal Studies value for NHS inflation of 7.4%, our hospitals are 272 million short in the last 4 years. So the questions are, 1, have you looked at the CCG spending on the acute hospitals in the light of inflation? And 2, would you agree with me that this lack of spending on the acute hospitals by the CCG is the major cause of the acute trust's financial problems? And I've got the figures and graphs with me if anybody wants to see them.
Okay, I think that might be one for you.
I think we've reached the point in the afternoon where this really is a question for me, which is I'd perhaps prefer to pass this one on. I'd love to talk about the numbers with you afterwards. Forgive me, I don't recognise the numbers you've just described, but I'd love you to explain them to me afterwards, and then I can have them in mind. In terms of how CCGs pay NHS trusts for hospital-delivered care, I'm sure that you know this, but there may well be people in the audience who are not familiar with the financial transactions in our NHS. So predominantly, it's driven by a thing called payment by results. And payment by results means that there is a national price that is set for thousands of things that happen in hospitals. So, for example, there is a price for an A&E attendance. There is a price for a hip replacement, and so on. And so the CCG each year will pay, in this case where we are now, North Cumbria Acute Trust Hospital, or if people from this part of the county access services in Northumbria or in Newcastle or in Middlesbrough or anywhere else, we pay that price for each of those interventions times by however many times they happen. That's broadly how the system works. Now, one of the problems, and this has been acknowledged nationally, is that for some parts of the country, the payment by result price does not reflect the cost to deliver the healthcare. And that's particularly the case in relatively small district general hospitals. So, some of us spend quite a bit of time at Cumberland Infirmary, Carlisle, and indeed at West Cumberland Hospital. They don't feel like small places, but believe me, they are. They are very small hospitals in comparison with lots of other parts of the country. And that means that they have diseconomies of scale. So some of the services simply cost more to deliver than the national payment by results would mean that they would earn for those services. And then I guess there's also a challenge potentially of, in a place like West, North and East Cumbria, with a very dispersed population, spread out over a large area, is our part of the NHS appropriately resourced in terms of the funding allocation that even comes to the CCG in the first place? And that's a discussion that we've been in with government. But I think one of the challenges from government is you need to demonstrate that you are doing everything you possibly can to deliver high quality but efficient healthcare before we're ready to have a different kind of conversation about how money flows into your local part of the NHS. So hopefully I've picked up some of your question. I'm very happy to look at your numbers afterwards. I simply can't arithmetically see how they could be arrived at, but please do explain it to me afterwards.
Do you want to do a subsidiary?
First of all, it's not all payment by results as a block grant. We know that the payment by results tariffs have gone down year on year because the government are squeezing everything. And if you said try and get out of it with just payment by results, you'd have to show us that the number of cases going through were dropping commensurate with the amount of money you've or not actually spending at the hospital now that you were before. So you'd need to show that the admissions were going down in parallel with the fees that you're paying into the hospital were going down.
I can show you two things. One is that throughout my professional experience in Cumbria Primary Care Trust and subsequently in Cumbria Clinical Commissioning Group, every year, the Commissioner has invested more money at North Cumbria Acute Hospital Trust than the previous year. Yes. In every year. So that's one thing. Sorry, in fact, can I answer your second point? You're right, there is a block element, which has, in my experience, every year been smaller as more things have moved to payment by result tariff. And there's another element, actually, which is for particular high-cost drugs that are not included within the tariff, and we simply pay what they cost. But I am very happy to go through this with you afterwards. But honestly, every year, the investment in acute trust hospital services in North Cumbria and indeed in neighbouring trusts has increased.
But if it increases less than inflation every year, the gap between what just the state level and what you actually get gets wider every year. It's obvious, isn't it?
Can we just put the microphone up a bit closer to you?
If you, for instance, paid 2% more to the hospital every year, but inflation's 4% more every year, the gap between what you can do with that money and how much you get increases year on year.
Okay, I think, Sonia, would you going to come in there?
You sound like somebody who knows quite a bit about public sector finance, and we're not therefore going to be able to reconcile this debate here. I would just point you to, and I don't know whether you've had a chance to look at this, one of the appendices for the consultation document is something called the pre-consultation business case, which is on our website, which has pages of financial and other analysis. And if you and Peter aren't able to have a conversation about that, you might like to have a look at that, because I think it will explain many of the points that you make. Let's just be clear. Any part of the National Health Service could probably construct the same kind of argument that you are, that because of the price of inflation, there is not enough money coming into the service. That is the big public debate at the moment. Notwithstanding that, we have a responsibility to live within the resources that are allocated to West, North and East Cumbria, and that's part of the thinking that we have been pursuing. Having said that, I think there might be a case for additional resource for the particular circumstances that we face of rurality and sparsity of the population and so forth. And we are prepared to argue that case with the government if it develops as it might do over the next few weeks. But I mention that more in hope than expectation, though. That's something, though, that we are alert to.
Okay. I had the lady in grey, I had the gentleman with the check shirt, and I had a lady with the fur coat on, fur coat on. A bit of it's got, maybe it was fur at one time. Lady in grey to start with, and then we'll go that way round, and then we'll see how we are. Just here? Yeah.
Come back to me.
Well, you had your hand
I've
up.
even forgotten what I was going to say. What I would like to say, though, is what that lady said at the front about the number of responses back to the local newspaper.
Yeah.
And it may well be that a lot of this is because of the historical culture in Cumbria. And again, you know, we have to learn lessons from the past. And I'll just endorse what the lady said. But I do think what you might be coming to is a flawed consultation.
Okay. And the gentleman in the check shirt?
We've heard that this consultation or these proposals aren't driven by efficiency savings. I would like to know, when it's all done and dusted, will the Trust still have the same number of doctors, nurses, ancillary staff and beds? And if not, what is the scale of reductions? And does the preferred option in every case equal the lowest number of employees?
Okay, so I think it's kind of a workforce question. Are you able to answer that?
I am in part. So we have modelled through for the preferred options what it means in terms of beds, and it would mean potentially by being able to prevent people coming into hospital in the first place and being able to get them back home quicker rather than them lying in a hospital bed when actually that wasn't the best place for them, that we could take out possibly in the order of 100 beds across the sites, the 2 sites. I think what is really important to say is that our staff are absolutely fundamental to delivering these proposals. And as we start to work in a more integrated fashion across the entire area and share our staff and our teams and have broken down the divides between our organisations, I have absolutely no doubt that there will be a place for every single professional person, and we will still want to bring in more. We will still want new talent, young professionals, new types of professionals coming in. So I most certainly don't see this in any way as a threat to any of our quite wonderful staff at the front line.
Okay, I think the lady with the black coat on, should we call it that? It's coming.
It's coming. When the lady was talking about the revisiting consultation, I think that's really very important because we've had systems introduced which, in my mind, are just rubbish. One of them was the Choose and Book. And if anybody's experienced using Choose and Book and the problems that are related to it, it was far better. When you went to the consultant, you were given an appointment by the secretary. Great. You knew exactly what you were doing. If you couldn't go, you just cancelled it and you got another one. And now we have this ridiculous system where recently I had an appointment and I couldn't get one because it wasn't there. And they get a phone call from Milton Keynes. Why haven't you booked an appointment? How stupid is that? Another system we have is the 111 NHS call. We had a very good system when we had the CHOCS system out of hours. And now this is a national number, which is obviously ridiculously busy. Why can't we go back to having QDoc?
So is your question is about revisiting information that we've already got from consultations, or is it do you want specifically a response around 111? Okay, do you want to make a comment about the kind of intelligence that you've used to perhaps build the business case? Because I think that's what we've been alluding to as well. There's other information in your business case that you've used to design where we've got to. Does that include some of this stuff?
I can say something about both issues. Yeah. So I guess while we're doing all of this discussion and hearing views, we're particularly focused on the specific areas where we are consulting, but actually it's a real good opportunity to get lots of feedback about other parts of the health service. And Choose and Book is one of those. So we're not consulting on Choose and Book. It's a nationally driven initiative. It's been in place for some time. I think in some areas it has really helped patients to be able to have greater choice about where they have particularly elective procedures and outpatients. It has helped in some places to drive down waiting lists, and in some places, and there will be other people in the room who've had a bad experience too, it can be confusing and it can lead to delays, and Choose and Book does not always work perfectly. So I think we've just got to accept Choose and Book is imperfect and we need to keep trying to improve it. On 111, you're absolutely right. Again, it's a national initiative, so there's no choice about having 111 system. You have to have it. One of the things that we've been trying to do, and I think we've been getting more successful around this over the last few months, is for there to be a much better connection between the part of North West Ambulance Service, which runs 111 in the North West area, including in Cumbria, and with Cumbria Health on Call, which is our out-of-hours GP service. So increasingly, there's a relationship between the people who answer the phones at 111 and how they can get a clinical opinion from our out-of-hours general practice service. Up to and including now, and Rick, you may want to say something about this, I don't know, whereby even some of the calls going through to on 999 are actually appropriately being screened and being taken by our out-of-hours GP service to make sure that people get the best response as well. So we are trying to make the best of 111, which does offer great advice, by the way, for people all the time. So I don't want to decry it as a service, but we're trying to really connect 111, particularly with our Cumbria Health and Call colleagues for out-of-hours general practice. And then we will be seeking to have the same kind of links with daytime general practice into the future. I don't know, Rick, if you want to say something about 111.
Yep, certainly. We've been working very closely with 111, obviously through to our CHOC colleagues. And what we're now at the point of is that for Cumbria, some of those calls that do go to 111 will be going to our CHOC colleagues and not to 111. So we're working further along the line to define a larger list of the codes within the code sets that we use for categorisation that may be suitable for additional to be added to that list. But certainly already we're now at the point of those calls going back to CHOC.
Okay, ladies and gents, we're at, I think, 2 minutes past or 3 minutes past or whatever. Are there any further questions that people want to ask before I suggest that we close this meeting down? Gentleman's got... Anybody else got any final questions? Gentleman over here is going to ask, I'm sure, a summative question.
May I go back to integrated care communities and the concerns I have? One of the reasons for closing hospital beds is the lack of staffing and the difficulties with recruitment. Integrated care communities, and those of us who work within the community, will need to have both resource in terms of finance and also people to work to provide the care for early discharge from stroke, to look after the very frail elderly. And the lady over on the left made the comment about the difficulties with home carers and in terms of agencies being available to look after the very frail at home. That all comes down to staffing, and it's perhaps the conversation we had very early on this afternoon in terms of recruitment. And really the question is, how confident are you that you will be able to staff the community appropriately to give the people of West, North and East Cumbria the care they need and deserve?
Okay, so there was something about affordability, but you specifically focused on recruitment. Okay, do you want to...
Yeah, you're absolutely right. That is going to be a huge, great challenge for us. One of the things that we're looking to do, as well as the longer-term work with schools and universities, is developing new roles and new skill sets, so that you don't have to wait so long for a doctor to come out. You don't have to wait so long for a nurse to be trained or an allied health professional to be trained. And we're looking to develop a whole host of new roles, working in partnership with the universities and higher education sector. Just one example, and it's purely about the medical workforce, is the development of physician associates, which will be a cohort of people who have graduated in a science discipline from university and then will go on to get further university and healthcare training in providing the kind of work that supports doctors in what they do. So they'll be trained in doing physical examinations, in doing basic procedures, always under the supervision of qualified staff and personnel. And it's through initiatives like that that we will increase the breadth of the workforce and have more hands-on people doing the work, which is actually where the biggest difference is made. So we're looking at that and looking to develop similar roles within nursing and within allied health professions as well. But absolutely right. A service that depends hugely upon its people is going to stand or fall, and whether it recruits, trains and retains people with the right skill sets.
Okay, final question from the lady down here. Can you hold on 1 second and we'll just get the microphone for you?
It's just about people coming out of hospital and home care being put in. And do the majority of people realise that most of these people who go on to home care have absolutely no training whatsoever? And I know that for a fact. They get no training. They apply for a post with an agency, I don't know, I can't mention them, and they will be interviewed, and they will be police checked, and they will be put into the community, and they will have had no training whatsoever in looking after the vulnerable people that you want to put in the community.
You raise a question particularly about the social care workforce, which, as we said before, is more directly aligned to the county council and the organisations that they commission. But the point that you make is also very relevant in healthcare. The vast amount of hands-on care is delivered by people who are not professionally qualified, and traditionally their training and their support needs have been neglected by healthcare organisations. And that's one of the things that we're coming together to address. So what's called the Band 2 and Band 3 workforce, that's people who are not professionally qualified or registered. That's a big initiative that we're looking at with Health Education North East and Health Education North West to see how we get appropriate training to those people and appropriate access to supports.
Debbie, do you want to?
You're right, you're picking up on the social care elements as well. And of course, social care is absolutely critical part of the integrated care communities. I absolutely agree with you. I absolutely agree with you. So areas in which initiatives like integrated care communities have worked have done that. They have worked very, very closely with home care providers and their staff, with social workers and others to ensure that the training is there. And we must learn from that and do exactly the same. Those staff must be supported both within residential nursing homes and home care workers to have the sort of training to be able to deliver high quality services. You're absolutely right. I'm sure, and quite rightly to be.
Ladies and gentlemen, I think a few people have got other appointments they need to get to. So with your permission, I'll kind of close this down, but just to say a couple of things to finish. One is, please find a way to respond to the consultation, because it's only by you writing things down that the CCG can use your views to influence their decisions. So it's really important that you record what it is that you want to say. Second is obviously to thank you for coming. And the third thing is that I think Debbie said it, things like this should be the start of ongoing dialogue with people who use services. And I would certainly advocate that kind of on your behalf, that things like this continue throughout this process. Don't just finish a dialogue with you. during the consultation process, but implementation, there should be dialogue within that as well, and I hope that continues. So thank you very much for coming, and have a safe journey home.